a little bit against the mainstream, I fear. I will talk to you about stem cell transplantation in ADA2 deficiency. I will start with the experience that I had in 2 patients of mine, and then I will give you a global overview thanks to the collaborators here in the audience. So, as you've all heard today, this afternoon and this morning, ADA2 is secreted mainly by monocytes and macrophages, so it makes a lot of sense to try and think of replacement of the hematopoietic system or the immune system as a potential treatment for ADA2 deficiency. Also, of course, I think we're all convinced now that the severity of this disease really, let's say, can argue with a stem cell transplantation, or can at least support a stem cell transplantation as a potential treatment in this disease, because it can be really devastating. Also, there are maybe some concerns maybe in the long term about treatment of these patients, especially if they also have an immunodeficiency or a hematopoietic phenotype as a long-term treatment. And so we have seen that at least in a long-term follow-up for some patients of 9 years already, it can be a definitive treatment for these kids without the need of any additional treatment. So we've learned today that there's actually a huge spectrum in phenotypes in these kids and in these adults, and I don't think I need to repeat all of this, but I think we've learned also today that there is a lot of immunodeficiency involved, or there are patients with problems with herpes infections and so on. There's also immune dysregulation, it's nicely described by the group of Bodo. So I think it's really important that we realize that it's not only strokes. So I'm going to tell you about the first patient that I transplanted. Actually, he presented at the age of 6 months with severe RSV, was admitted with RSV infection, actually very sick, and he was found to have hypogammaglobulinemia, IgG was low, IgA and IgM. Okay, it was seen as a transient immunodeficiency and a cause of bad luck. But at the age of 12 months, we saw him with Staph aureus lymphadenitis, again quite sick, and with that he had a syndrome of lymphoproliferation, and he was noted to have pancytopenia with it, and it was refractory to treatment. After the hemato-oncologist had found out that it was not leukemia or HLH, they sent him to me, and I thought, you know, this could be an ALPS-like phenotype, and I sequenced many genes that could have caused this, but I didn't find a solution. And also, I didn't find a good treatment for this boy, because all the things I tried didn't work out. So in the end, I was left with a boy that wasn't growing, that wasn't thriving, and had been on many treatments, so we decided to go for a transplant, a sort of blind transplant with his matched sibling donor. Fortunately, a couple of years later, he got another sibling, a younger sibling, and then with the tool of whole exome sequencing, we found that these 2 boys were actually homozygous for a well-known mutation in CECR1. Also, we proved that it was actually the problem in the first patient we didn't have a stored serum sample, but we had, of course, a serum sample of the new sibling at hand, and we proved that we could treat this disease. Now, to tell you about the course of the transplantation in this first boy, we at that time transplanted it with, fortunately, a non-carrier sibling, and we gave him bone marrow of his sibling after oral BU, cyclo-ATG, and cyclosporin A, which was at that time the most used conditioning regimen in Europe at that time, and actually had a quite severe course, let's say burdened course with persistent deep thrombopenia at day 28, slow neutrophil engraftment, so many concerns, and finally at day 36 he did what many patients with ADA2 deficiency have. He had a stroke of the pineal gland. At that time, we gave him rituximab, and he recovered his platelets. And finally, in day 60, he also had a severe veno-occlusive disease, and also this was before the age of defibrotide. So we were a little bit annoyed by this course, but in the end, he's now 8 years out of transplant. He's alive and well and of all treatment, and we also demonstrated that he has a normal functioning immune system, with recovery of all the defects he had prior to transplant. Some interesting feature that we noted, and a little bit to respond to this, we had also in our group a patient group with Castleman disease-like phenotype, and they were actually treated with anti-IL-6 and had, after that, they had a recovery of their growth and they had a resolution of their Castleman disease phenotype. And we also measured IL-6 levels in the serum in our patients, and what we found was actually quite striking, that it was really high around his transplant course, and then it settled down several months after transplant. Whether this was a coincidence or not, it's difficult to say with this single transplanted patient, but I will show you the data on the other patient later on. So then, of course, a couple of years later, his sibling brother came there, and at first we screened him at birth, immunological level. Everything seemed normal with what we had at hand. Unfortunately, bad surprise, he turned up to have what we thought was a transient erythroblastopenia, or let's say a purette cell aplasia induced by HHV6, which we proved was an acute infection, and he showed up to have a very severe anemia. After that, we kept a closer eye on him, and we saw him many times with extensive HSV infection, mucocutaneous, quite extensive, but we couldn't find anything in his immune screening over and over again. Then he developed lymphoproliferation. Then he went on to have bowel obstruction, very severe, with progressive lymphopenia at that stage, and also progressive hypogamma, which again strokes or is in agreement with the finding that when inflammation goes up, probably the immune system is suffering, and that there is at that time a production of hypogammaglobulinemia. So at this time, we found the gene defect, and we decided to keep him for a little while on sirolimus because he had been very stable. He had shown low IL-6 levels at that time, and he was better. Unfortunately, then he developed a transient ischemic attack, which was when we are developing to transplant him as well. And then finally, at age 5 years, we decided to do it because it was difficult for the parents to adhere to a schedule of giving a etanercept. Moreover, it's not so easy to get hold of TNF-Inhibitors for this indication, and so the parents decided that they would go for a transplant. Okay, now I will show you his scores because I thought this time I was going to be smarter. So what we did, I gave him etanercept day -14 prior to transplant, and I also gave him etanercept just prior to infusion of his stem cells. Unfortunately, I didn't have, was not an HLA match with his healthy brother, so I had to use a matched unrelated brother donor, 10 in 10. I gave him Campat, triosulfan, and fludarabine because I wanted to avoid at any chance to have a new veno-occlusive disease event. And we gave him PBSCs. And actually this time, he engrafted quite well. Only the neutrophils were a little bit slowish, but in the end, he engrafted well. And what was really interesting is that we had a very quick recovery of his adenosine deaminase 2 enzyme activity in the blood. So when you see here, this is a time of transplant, and this is actually the monocytes going up in his blood, and the neutrophils, and you see that at the time of, let's say, neutrophil engraftment and monocytes coming up in the peripheral blood, we also get a correction of the other two levels. Together with this, if I go one slide back, so he had this severe attack of bowel problems with actually something that resembled appendicitis to me. And this was completely resolved at the time his plasma adenosine deaminase activity went normal again. So it was completely compatible with his ADA2 activity in the blood, in the plasma. So then again, I was also intrigued by the interferon alpha and the ISG signature of these patient cohorts. And of course, it's not the best way to prove that there's any link to interferon alpha. I know that very well, but I thought it was interesting while we were measuring cytokines anyway to measure interferon alpha in these patients in his blood, in his serum. So what we found at the moment that he for the first time showed livedo and he had this severe appendicitis with ileitis and his new hemorrhage, his levels were really high. So it was above 100 picograms per ml for interferon alpha, which went down when we conditioned him, you see here. At day 0, unfortunately, I don't know how he did it, but he got influenza. And so in his protective room, he got influenza, but you see there's not so much of interferon alpha around at that time. Then he got adenoviral reactivation together with, again, a rise in interferon alpha. So here, at this time, we couldn't check, we couldn't find any virus that was actually responsible for this surge in interferon alpha. So I think there's more to say about interferon alpha or type 1 interferon signature in these patients than we know at present, and what's also shown in these afternoon sessions. As for TNF-alpha, I think this is also quite interesting course, and for IL-6. So you see again, day 0, day of transplant, we see a huge rise in TNF-alpha at the time of transplant. Maybe yes or no induced also by the etanercept administration at that time. And then again, you see a huge rise in IL-6 post-transplant. And unfortunately, again, a rise some weeks after, which I will explain later to you. So actually, in his late course of disease, we had a trouble because at one day he presented with fever, and he presented with anemia, very deep anemia. And actually, when you see here the dots, we had a very nice course of ADA2 activity in the plasma, but at one point it dropped completely. And also his chimerism that was 100% all the time dropped to 60%. So this was really annoying. It should have been enough because his enzyme levels, activity levels are in the normal range, but it dropped and he's still suffering from red cell aplasia. So again, we used all the tools we had. And at the last tool I gave him, so I gave him steroids, I gave him cyclosporin, higher doses, I gave him sirolimus, I gave him rituximab, high-dose IVIG, all of that, and nothing helps. And so I finally resorted to bortezomib, and there I see finally an increase in his reticulocytes. So this is not such a good way, and probably I will have to boost him in one time or another. So, okay, those are only 2 patients from one family, but thanks to the contributions of Dennis Hickstein, Dr. Zaza, Dr. Kranz-Bertok, von Monfrans, Hashem, Dalal, Ashish, and Dr. Jordan, I think all who are here in the audience, I was able to collect data on 8 patients. And so you will hear more about one of these patients in a later session. But I think it's really important. So 8 patients with adenosine deaminase 2 deficiency have been transplanted. So the mutations are a little bit varied, but many have this same mutation as the Leuven patients. The presentation and the indication for transplant is also a little bit variable. You have a patient here that has been published as well, the NIH patient that was taken for a GATA2 deficient patient who was actually admitted with a monomac phenotype and then went on to develop invasive fungal infection. So this was a patient with a GATA2 presentation. And then you see many patients with PRCA or with a failure in myelopoiesis, diamond blackfan anemia-like phenotype, our patient with the ALPS-like phenotype, and then the patient in Utrecht also with a combined phenotype of a sort of lymphoproliferative syndrome. So these patients were all taken to transplant at various ages. You see from 6 months up to 20 years of age. And for what we could find and what I could analyze, the conditioning regimens are quite diverse, as you can see. Mostly myeloablative, but some reduced intensity conditioning. Stem cell donors are also diverse, but what you could see, except for the latest chimerism in my youngest patient, it's quite good. So the chimerism is quite good. And the ones who have checked adenosine deaminase activity and levels, they have all normal levels. And the outcome is important. In 8 patients, we have 8 patients alive and well. So that's an interesting feature, and none have had any further strokes and etc. Now, there is a little, besides, of course, the issue of transplant, there's a little downside to it. There have been 3 second procedures, of which 2 were related actually to choosing a donor that was actually carrier or a diseased carrier of a mutation. And also, I think it's important, we had a VOD which came quite late. So the question is, do we really need to take care of this because we've seen about the liver, so the endothelium doesn't like too many attacks, so I think it makes sense to take care of the liver during transplant. All right. And I think one issue here is that there is, at least in 4 patients, there has been mentioning of autoimmune manifestations, which I think also makes sense, especially with what we've heard today about the B-cell phenotype, maybe long-lived plasma cells, I don't know. But I think that is also something that we have to take into account when thinking of transplanting these patients. You will hear more about some of these patients in the next presentation, but I would like to thank again the physicians who contributed and who gave me their data to share with you. So I think we can conclude that stem cell transplantation can be a potential curative treatment for adenosine deaminase deficiency. So the issues might be VOD, might be a flare of inflammation. There might be an increased incidence of post-transplant autoimmunity. I don't know very well how to define and how to explain it. And then, of course, we should also consider, listening to the previous talks, who to transplant, who to take to transplant of this large group. Probably not the patients with solely stroke phenotypes, but those with a more combined phenotype. And I'm happy to hear about more transplants, because I would like to bring those data together let's say, in an overview work. Thank you.